Good morning, everybody. My name is Dr. Yamal Patel, and I am a consultant obstetrician gynecologist and a director at Third Park Hospital, trustee of the Lap Machinani, and the immediate past chair of cases. Welcome to today's talk on hysteroscopy setup, equipment, instruments, and the OR arrangement. So we're going to start off with the basics of hysteroscopy setup and equipment. What is hysteroscopy? It's an endoluminal endoscope that aids to visualize the uterine cavity. So we have to view the internal aspect of the uterine cavity, and it can be used for a variety of intrauterine procedures. Hysteroscopy is derived from the Greek words hystros, which is uterus, and scopy, which is to look. So it is to look into the uterus. It can be used for diagnostic and therapeutic purposes. It is used for a number of procedures. We'll go into that, but today our focus is mainly on the equipment and the setup. So to start off, let's understand what we mean by the great pillars of a good MIS surgeon. The pillars of a great MIS surgeon is the ergonomics. Know your ergonomics well, know your task analysis well, break it down into sub-steps, know your engineering, and definitely know your anatomy along with the knowledge of the disease. So today our focus is therefore on engineering, because this is all about the engineering of hysteroscopy in MIS. I have with me Humphrey, who is a trained MIS nurse, and he's going to be helping me demonstrate this equipment. So we go into the OR setup. As seen in this slide, you will see the OR setup of a hysteroscopy theater would be having the patient on the bed, the anesthetist and the anesthesia machine at the head end. The surgeon will be actually at the lower end between the legs being put up in lithotomy position or semi-lithotomy position. We have the fluid system, that is the management system, on one side, and if possible all on one rack. We have the electrosurgery if needed for operative procedures. We have the monitor and the light, and we have a scrub trolley which will be appearing like this with all the equipment, and all the instruments on it. So that is the setup. This is the picture of the setup that we would expect of the hysteroscopy theater. Now we start off with the hysteroscopy cart. So let's see this as a cart that is for MIS. We have different, so Humphrey, if you can just show us the different parts. We'll have the monitor up there. In this one we have monitors on the boom arms. Then we have the equipment which will come in the hysteroscopy cart will be the camera processor. We have attached to it will be the camera. We have a light source. In this one it is the same equipment. In other towers you can have the camera source and the camera processor and the light source separately. We have the fluid management system. In this case we have the fluid management system. We're going to go through these one by one. So fluid management system of different companies appear differently. They're all serving the same purpose, but we'll discuss more in details about this. We have a suction machine, which is the regular suction machine out there behind. If we can just bring the suction machine. So that would be the suction machine back in front. So this is how you would set up. Put it down here. All right, so suction machine, and you may have an energy source. In this case, this is the energy source. That's the energy source that we may use for for surgery that involves electrosurgery. Let's go into the instruments that we are going to be discussing one by one. We have telescope. So this is a telescope. So we'll go into the details about a telescope. We have the hysteroscopy sheets. So we have the hysteroscopy sheets. We have the shaver. This is a shaver. We'll go into it. We have a resectoscope. These are instruments. And we have operating instruments, along with the regular DNC set where you'll have a speculum and maybe dilators and a valsellum sometimes to hold the cervix. So this is how you would set up a hysteroscopy trolley. And these are the operating instruments. We'll go into them one by one as we move on. In consumables, we will need hysteroscopy tubings. We will need the cables are all part of the equipment. We will need hysteroscopy tubings. We will need normal saline. So that is the fluid, the normal saline. You may need some tubal cannulation equipment or instruments which are consumables in this case. So let's start off with the light source. The light source, we're going to take it one by one. If we can connect it, the light source is actually of different types. We have had tungsten light source. We have had the halogen light source. We have had the xenon light source, which is a halogen. And then we have had now the LED light source. So the latest one is the LED light source. So that is a light source. You can use this. It's a fiber optic cable that will connect from the light source all the way to the tower, to your equipment. So we'll be connecting that as we move on, as I show you. But that's briefly about the light source. The cables, we have either fiber optic cables like this one, which is the most regularly used cables. And then we have the liquid or the liquid crystal or gel cables, which are less flexible. They are a bit durable as well, and they do transmit higher intensity of light. But the problem with those is, one, they are a bit more expensive, and two, they are not easily available. We then move to the camera. So you will need a camera, and this camera consists of the camera head. We have obviously the cable, and we have the camera control. Okay, so this CCU camera attaches to the eyepiece of the scope. So it attaches to the eyepiece of the hysteroscope. In this case, yes, you can connect the camera. So we have the hysteroscope that attaches to the eyepiece of the telescope. The different parts of the camera, the different parameters that we would use is the definition. We have the standard definition, HD, Ultra HD, we have 4K cameras, and we also have 3D. We have the sensitivity, the resolution, we have zoom, we have focus. So that's what we would use this camera and the settings for. We're not going into that so much in detail. We next move to fluid delivery. So we need fluid, and we need a fluid delivery system. The fluid delivery system are of three types in hysteroscopy. We have gravity, where you connect it to this fluid and you have the tubing. We can have the regular twin tubing. We can have, these are all tubings for hysteroscopy. And then you can have the tubings that connect to these machines. So that is gravity. And it's important to know that when you connect a tubing with a bag that is 1 to 1.5 meters above the level of the patient, you get around 40 to 70 millimeters of mercury pressure that can be used to distend the uterus cavity. The next one you have is with a pressure bag. So you can have this pressure bag to connect and put inside the tube. He'll show you how we'll do it. So that's one other option, that we have the pressure bag, and with that you have the pressure that can be created in this bag to deliver the fluid a little bit under pressure, and therefore you can get a better distension of the uterine cavity. And then the third one is where you have this fluid connected through pumps like these. So these are called hysteroscopy pumps, or the fluid management system. And the hysteroscopy pumps are actually the most accurate way of delivering the fluid. Now let's see the difference between these three. The difference between these three is, number one, if you do gravity, you're going to have variable pressure and variable flow, which means you're just letting it go by pressure, and depending on the pathology, the uterus, the flow inside will change, and the pressure also will change because it's just relying on gravity. Then we have this method where you're using a pressure and setting it to a certain amount and pushing it through the pressured bag, cuff bag. You will get variable pressure. Please remember what I'm saying. Variable pressure intrauterine, but constant flow, because you're constantly pushing it at a certain pressure and it's constantly flowing out. But the pressure inside, so when you suck or when it leaks, the pressure inside the uterus will change, but the flow will remain. The flow will remain constant. Okay. The third one is using the hysteroscopy pump. So this is now the pump, and this is the most accurate, because what we are trying to do is constant pressure, variable flow. This is the only system that can give you constant pressure, variable flow, continuous flow hysteroscopy that we want to work with. So what is recommended fluid delivery? It is, number one, constant flow. Number two, constant pressure, and continuous flow, constant pressure, variable flow hysteroscopy. That is what is recommended. Why? Because it is safe. It gives you a good view of at all times. When you get a constant pressure, when the water leaks out and then the cavity is supposed to close back, the pump pumps in more. When there is a little more and it's not leaking and there is too much already distension, the pump slows down. So it gives you a constant pressure to give you a constant view at all times, whereas the flow will keep on changing based on the machine. And because it's continuous flow, it clears any debris quickly, and therefore you have a good view at all times. So please remember these three words: continuous flow, constant pressure, variable flow, hysteroscopy. So we have fluid management system that is involving the pressure and the flow, and then you also have fluid management systems, as you will see there with the Medtronic system, where they have the in and out measurement. So remember, in hysteroscopy we are working in a very small cavity in the uterus, which can also intravasate vessel fluid also through the tubes, and it will have leakages. So how would you know how much fluid the patient has taken in? And if we are not sure of that, you will likely end up with overload of fluid, which is dangerous. And therefore, having a fluid management system and recording and documentation and someone specifically in charge of fluid inside the theater is very important. Keeping a tab on the in versus the out, and the difference in the two is called the fluid deficit. So the most important parameters to us would be pressure, flow, and deficit of volume. The next equipment we have is the suction machine, which is standard for every other thing. And then we have the electrosurgery machine. So this is the electrosurgery unit. We have another electrosurgery unit there. The electrosurgery unit is going to be used when doing operative work inside the uterus, let's say for the septum resection, or for metroplasty, or for fibroid myoma resection, or for Asherman sometimes, you would use energy. And you will need an electrosurgery unit. It's important to know the settings as well. Let's see, we will try and cover that as we move on. The energy sources that we can use would be the monopolar, would be the bipolar, would be the resection, which can use either monopolar or bipolar, and sometimes we use laser. So, in hysteroscopy pump, back to this, we are now going into the settings. The pump settings are the preset maximum intrauterine pressure, the preset maximum intrauterine pressure, the preset maximum flow rate, the actual flow rate, and the volume of fluid. So those are the 4 parameters we would be monitoring. So preset maximum intrauterine pressure is the most important among this, and the guide to it should be the mean arterial pressure, the MAPS. So the mean arterial pressure is actually the average arterial pressure that is throughout one cardiac cycle, systole and diastole included. So when we talk of the mean arterial pressure, it's calculated by diastolic blood pressure plus 1/3 the pulse pressure, which means diastolic blood pressure plus 1/3 systolic minus diastolic pressure. Try staying at or around the MAPS for safety, and keep in mind a maximum intrauterine preset pressure of 100 millimeters of mercury or below. That is just for safety purposes. Sometimes if you want to get a better view, then you might go higher, but otherwise the higher you go, the more intravasation of fluid through the tubes or into the vessels in the myometrium might happen, especially if you're resecting into the myometrium. The flow rate setting of these pumps should be set to between 200 to 400 milliliters per minute. So those are specific values that I want us to remember. The volume is not important. The volume of fluid used may not be as important as the fluid deficit. So the important parameter in volume is the deficit, which means the volume in minus the volume out is the fluid deficit. How do you keep that in tab? Because you will be having leakages through the cervix into the floor, into the bucket, or on the drapes, or under the patient. Second thing, you will have fluid that would be intravasating through the uterus vessels. You will be having fluid that will be intravasating into the patient's abdominal cavity through the tubes. And keeping a tab of all this is very important, because the fluid deficit parameters that are important is depending on the fluid used, whether you're using normal saline or you're using a hypotonic solution, would be the maximum allowed deficit. And I think it will be covered in the fluid management talk. Now, we go into the instruments one by one. So we are starting with the telescope. So this is a telescope. A telescope consists of the eyepiece, the light adapter, the barrel, and you have the objective lens. So this eyepiece and the adapter has 3 connectors here. Depending on the type of cable you may use to connect to these. You can connect the tubing, the light, yes. So this is how you would connect the tubing to the eyepiece, to the light adapter. And these are defined or described based on diameter. So these are diameter of the barrel. This is a 4 millimeter scope. for hysteroscopy. This is a 2.9 millimeter scope, and then we also have a 1.9 or a 2 millimeter scope for the office hysteroscope, which is the mini hysteroscope. Then it's also described based on the angle. So this, it's all written here. This is a 12-degree scope. So this is a 12-degree hysteroscope, and this is a 30-degree hysteroscope. So we'll be explaining what that means. So a 12-degree, a 30-degree, a 0-degree are available. You also have a 45-degree and a 70-degree available. The 0-degree is good for panoramic view. The 30-degree or the angled views are very important for the operative procedures and to look at the sides. So for example, viewing the ostia is important. Going into an abnormally shaped uterus is important to use angled scopes. Hysteroscopes are divided into rigid, like these, or flexible. These are rod lens based. So there is Harold Hopkins rod lens in here. So these are called rigid, and rigid are more durable. They give a better, superior image. And we have diameters, as I've said, from 1.9 up to 4 or 5 millimeters for hysteroscopy. And they can be used for both inpatient and complex operative procedures as well. Then we have the flexible hysteroscope, which is sometimes used in office hysteroscopy. There is a flexibility at the tip with deflection of up to 120 to 160 degrees. It is good in irregularly shaped uteruses and navigation around intrauterine lesions, but it has its limitations in the kind of procedures that we could be able to do. So this is about the telescope of the hysteroscopy unit. We have the sizes we have described about and the angles of view ranging from 0, 12, 30 and 70. As a guide, it's important to please remember diagnostic, it's good to use a 30-degree scope. Operative with cold instruments, it's good to use the 30-degree again scope, like if you're using the scissors or the graspers. But when you're talking about doing resectoscopy, then a 12-degree scope is better, because when you have a 30-degree scope, if you're looking completely off your front view and your instrument cannot bend, your instrument will be cutting somewhere different from what you're seeing. So you need a 12-degree so that it's closer to your operative field. So resection, 12-degree. Diagnostic, 30-degree or 0-degree. Operative, cold scissors, 30-degree, or cold instruments, 30-degree. The next setup is the sheaths. So we have the inner and the outer sheaths. You have the next other scope. You can use this. Okay, this is a resectoscope. Okay, so we have an inner and an outer sheath. This inner and outer sheath, you will need to understand how to connect them first. So connection is based on aligning the 0 with the line with the 0 and no other way. So connect it, align it and lock it. When you do that, the next scope now goes in. So aligning these two, so there is two lines and there is a 0 written here. So the 0, the two lines should be in line. Connect it and lock it. When you have locked it, then this becomes a ready hysteroscope for use. Until then, it's called outer sheath, inner sheath, telescope. Outer sheath, inner sheath, telescope, combined, assembled is a hysteroscope. Now, how do you define this? This is a continuous flow, operative, diagnostic hysteroscope. So it has mainly two channels. We have the one channel that is in the outer sheath. If you can see this, So this outer sheath has some fenestrations here, and it has one channel with one connection here for the outflow. So you can hold this. Then we have the inner sheath, which again has two channels. So these two channels are connected to here. One is for operative instrument, and one is shared by the operative instrument and the fluid in, and one is the scope. So the scope is going to go, when you see here, the scope is going to go, if you look closely here, the scope is going to go into this round, smaller hole, and then there is another one here where the fluid that is connected will go in from, and so will the instrument that is here. So let's see this. So you can see where the instrument will come out from, see? So the instrument comes out where the fluid goes in from. So they share the same channel in this inner sheath. So we have the inner sheath with two channels, the outer sheath with fenestrations and one channel. And when these are connected, now what is important is it becomes a 3-channel hysteroscope. How do you connect it? You connect it so that the in is always usually closer to you, the out is away from you. So the in is closer to you, and it has an arrow here that shows you an in. And this has an arrow here that shows you an out. So you follow the arrow, or you follow the basic idea that the in will always be closer to the operator. Now, the next thing, why can't we interchange this? It's important not to interchange this, not because it's posing danger to the patient, but when you connect this, hold it, when you connect the in, remember fluid will be flowing in like this, and then going out and getting out through the fenestrations back. So reverse that and see what happens. The fluid goes out through the fenestrations and in through the center one, out this way. So what will happen is it will go this way and come back this way. If that happens, it will always pull in the fluid and the pathology towards your camera, towards your scope. So you will not be seeing anything. It will always be obstructed by the tissue in front. So what you want is to push fluid in to distend the disc cavity and take the fluid out from the sides, from the fenestrations. So you can't interchange the in and out. Please remember that. You want a good view and therefore a less resistance flow, and that is the way to get the view correct. So this is hysteroscope. Camera connects here, light cable connects here, in comes here, out goes here, instrument goes here. So done, that's hysteroscope setup. Let's move to the resectoscope. So we have 3 different resectoscopes here. You can connect these here. So as we are doing it, we are going to show you the resectoscope settings. So we have the resectoscope. One is in my hand. We have a second resectoscope here, which is from Olympus. We have a third resectoscope here, which is from Karl Storz, and we have different options. The resectoscope consists of, so I'm going to break this up, an outer sheath, an inner sheath, a working element, an obturator, and electrodes. Along with the electrodes comes the cables. So we have the cables that are used. So this is a resectoscope along with a telescope. So this is a resectoscope. Okay? Same here. Working element, inner sheath, outer sheath, obturators, cables, and a telescope. Okay, so that forms your resectoscope. Remember what we said? The angled scope that you use for resectoscope is, did you get it right? 12 degrees, not a 30-degree scope. Okay, so this is a 12-degree 4 mm scope, and then we have a 2.9, so 2.9 scope. So most resectoscopes are a bit wider in diameter. This resectoscope, if you can see here, is written 8.5 millimeters, so it is a 26 French. This is a 26 French, if you can look here, 26 French. But this resectoscope is an 18.5 millimeters, so this is a much smaller, it's a 6.5 millimeter, 18.5 French scope. So it is going to use a 2.9 millimeter telescope. These are going to use a 4 millimeter telescope. How do you assemble a resectoscope? We have the working element. You will take the electrode and connect the working element to the telescope, lock it in. The next thing will be to take the inner sheath and the outer sheath and connect these two and lock them. Then you will take the working element and this, connect it to the scope and lock it. And the last part would now be the hysteroscope that goes in and locks in. So this is a resectoscope connected. With that, this resectoscope has the ability to do both monopolar and bipolar resection. So you will see when it's bipolar, it will have two electrode connections. So 1 and 2, where you will have these two connect. So let's say this will connect here and this will connect here. So this is now ready for bipolar resection. Right? So this is for bipolar resection. If you see here, the electrode comes in and out, there, in and out. So as you can see, when it is not used, the electrode stays in. When you want to use it is when you would activate it and then come back. So that is called passive resection, which is the safe resection, not the active. So don't have it out all the time. So this is the resectoscope connected. You have seen the resection connected, and this is the third one, the resection connected. So you would have, these are all going to use passive resection. The common sizes, as we have said, is 22 French, 26 French, 29 French, and then we have these mini resection. This is 6.5 millimeters, which is an 18.5 French. So let's move on. When we talk of the electrodes that can be attached to it, we have different electrodes. So we have this, which is a loop. So we have a loop, as you can see there, if you can look closely. We have a roller ball. We have a roller ball. So this is a roller ball, a loop. Then we have a knife, so which is just a Collins knife. This is a straight, as you can see, just an electrode straight, a needle. And then you have obviously the rollers as well, and you can have some toothed as well. So this is the type of electrodes we have. The fluid inflow for resection is similar. The in is always closer to you, the out is away from you. The in goes straight, the out comes out through these fenestrations again. So the flow will be that way, going this way, back and out through here. that way, and this way out through here. So in here, out here. So the flow in the hysteroscopy and resectoscopy is similar. Very important not to interchange this. We now move into another instrument or equipment that could be useful for us, and it's important if we have it, and that is the tissue removal systems. So tissue removal systems or hysteroscopic morcellators are very important as well, and they are a very vital and innovative way of having tissue removal from the uterine cavity, which becomes a problem when we're using resection, because you'll be leaving chips of tissue inside the uterine cavity, and removing those chips is going to be a problem. So this circumvents that problem, and you have, this is the IBS, which is the integrated Bugatti shaver from Karl Storz, and we have a similar tissue removal system where you are, that is the TrueClear tissue removal system from the Medtronic. They work on similar principles. There is another one that is also called MyoSure from Hologic. So this is one. Having this here at this point, I'm going to demonstrate on this one. You will be shown the TrueClear system there on site. So in the Bugatti shaver, we have the two pumps. We have the in and the out, the irrigation pump and the suction pump. We have the tubings that will be color coded. So the in is always the blue, the out is the pink or the red, so that is the out. As you can see, the in is the blue, that is the blue, that's the in and the out. We are going to set up and show you how we will assemble this. So in this we have the inner sheath, we have an outer sheath, and we have the telescope is already integrated, and we have the actual blade or the shaver blade and the cable. So how do you assemble this? You would put the same flow line to 0 connected. So we have a 0, a line to line connected. Once it's in, lock it. Then we have, the next thing is we have the cable to which you will connect the shaver blade. So this is pull in, connect, lock, and it locks. So that is connected. We have the eyepiece here which connects to the camera. So that will be connected to the camera like that. So that's the camera. And this is where the shaver blade will go in, and that will be used for shaving, as you're seeing. This is going to be connected to the motor. So we'll just show you how it's connected to the motor, gently. And this then connects to the camera processor. We have the out, the fluid suction that connects to the back here. That's going to be now getting you your tissue out into the suction machine. So this connects to the suction machine. And the in, remember, as all other settings, is the one that's closer to you. So there are two here. The in is closer to you. So connect that. When it's open, it's always in line with the tubing. So this is open. So this is a setup that is ready for shaving. If you press this, can you show me? So you can see it's moving. So look here, that's the shaver blade that is moving now. So this is going to shave off the pathology, polyps, fibroids that are submucous type 0 or type 1. And this is connected to the suction tubing. where now it is actually pulling in the tissue back into the bottle where you can get histology sample from. So this exerts a suction effect and pulls in the pathology into the blade as it keeps on shaving it off by rotating and the blade going in that fashion. So this is about the tissue retrieval systems or the hysteroscopic morcellator. A very, very useful equipment. So having done that now, the next let's discuss. So that is about your tissue retrieval system or hysteroscopic morcellator. When disconnecting it, again, you would pull this back and then this comes out. Okay, no forcing. And same here, when connecting this, there is a red dot here that connects in line with each other. If you adjust it in any other way, you will break the pins. So this red line, red dot with the red dot should be the way to connect that in. Please keep these things safely. These are very fragile equipment. You don't want to have anything damage this. Now let's move on further. We now go into the operating or hand instruments. We have scissors. So this is scissors. And this scissors is 5 French scissors. And it's called a rigid scissors. So we have some of them that may be a bit flexible as well. So this is a scissors. 5 French, how do you convert French into millimeters? It's divided by 3. So 5 French is roughly 1.6 millimeters in diameter. So that's a 1.6 millimeter diameter scissors. Then you have a grasper. So this is also scissors. We have a grasper that can be used to grasp. We have a biopsy forceps that has a spoon-like so that you can take a biopsy, let's say while assessing postmenopausal bleeding or something suspicious, you take a biopsy. You have a bipolar needle. So this is a bipolar needle. So it's an energy instrument where you can see there is a small needle in the top and you connect it to the bipolar here, and using this bipolar you will actually be able to cut through adhesions or maybe do a metroplasty, lateral metroplasty or a fundal. So this is to be protected. That is your bipolar needle. Then you have a myoma spiral. So like a myoma spiral that is for open surgeries or for laparoscopic surgeries, we have a hysteroscopic myoma spiral. You can have a tenaculum that is used to hold the fibroids and pathology if it is fine. So these are specifically instruments, and you have instruments that are 5 French that are most common. I also have a 9 French instrument. This specific hysteroscope allows, not this one. This is the 5 millimeter. I have another instrument, a hysteroscope that can allow a 9 French instrument as well. 9 French is 3 millimeters instruments. So it's a bit more sturdy and wider. So that's about our instruments or operating hand instruments. Now we go to the tubings. So we're looking at the consumables. We have the tubings. So this is a twin giving set or a twin tubing just for direct. It's connected here, for example, for direct putting in the fluid through gravity. You don't need to just connect it, don't connect, just show. So it will connect to the water, and you can see it will have 2. So you can sometimes use it to connect to 2 bags so that you make sure no air goes in. So you connect to one, don't connect here. Yeah. And you connect to a second one so that you have an uninterrupted flow of fluid without air entering into the tubing. The second type of tubings would be the ones that are specifically for these pumps. You have seen how they connect to the pump, and then they have the pump that will control the pressure and the flow to maintain the environment of constant pressure, variable flow, continuous flow hysteroscopy system. Thank you. So we have then normal saline. You'll be discussing about the distending fluids that are available and can be used. At the moment here we have normal saline, and I think most of the focus nowadays is on going on these isotonic normal saline because it is safe and we can avoid complications with the hyper or hypotonic solutions that we have been having in the past. We can have tubal cannulation sets. These are for cannulating or blocked, let's say, conval ends. So they are like the way we would use ureteroscopy and ureter cannulation. So you can use it for tubal cannulations. So with this now, I think I have completed most of the equipment, setup, instruments that we have. You can see this is about normal cavity of the uterus. The procedures that we can be doing with hysteroscopy is very vast. You can do hysteroscopic myomectomy, hysteroscopic cervical or endometrial polypectomy, infertility assessment or pre-IVF hysteroscopy in preparation for IVF or for fertility assessment, Asherman syndrome, which happens to be one of the most tricky and difficult procedures because there is no specific landmarks that remain, septate uterus, T-shaped uterus, other abnormalities where you're doing diagnostic as well as operative, and you do metroplasty, tubal cannulation as we've discussed, hysteroscopic guided removal of displaced or lost IUCD or retained products of conception, or let's say foreign bodies like old bone fragments, spicules, hysteroscopic biopsy for postmenopausal bleeding, hysteroscopic tubal occlusion or family planning by using a sure occlusion device, the microinsert. So with this, I'm going to end now by just giving you a few of my principles of hysteroscopy that I want all of you to remember. As a parting shot, please, hysteroscopy is a one-man show. Hysteroscopy is not a simple procedure. It is more likely to give you complications than even a laparoscopy because the margin for error is very little. It has a very small operating field, which means it actually makes it more difficult. It doesn't have so much space for you to work with. It is usually a one-handed surgery, so you have one hand that's showing you the view, but it's only a one-handed surgery, which means there is little scope for traction, counter-traction in the hysteroscopy procedure, making it more difficult. The angulation, as we have said, principles, diagnostic, 30-degree scope or 0-degree scope, operative with cold instruments, 30-degree or 12-degree, but resection, preferably always 30-degree scope. To continue, please remember continuous fluid flow is important, constant pressure, variable flow system. Safety is very dependent on fluid management, so please understand fluid management well, and in your team always have one person who is responsible for documentation and announcing about the fluid deficit and the recording. The preset maximum pressure and the fluid deficit are the most important parameters. Vaginoscopic approach to visualize better while minimizing trauma and damage to the cervix. So try not hold, dilate, and then go in. Try vaginoscopic. So they will be training you on vaginoscopic entry. Another one, office procedures are very, very possible with minimal to no pain when you use the mini hysteroscope, and you can even do operative procedures like polypectomy, some myoma resection, some resections of adhesions, some metroplasty as well in an office setup without any dilatation and without any anesthesia. That is office hysteroscopy. The procedures are stratified, which means that not everybody should do every procedure in hysteroscopy. Please, it's not always simple. Know your limits. We have different levels. So diagnostic is one. Then you'd move to polypectomies, retrieval of lost IUCDs and retrieval of some products of conception of bony spicules, and maybe biopsies for postmenopausal bleeding. But the moment you go higher than that, then you go into myoma resections. That is a bit complicated. You go into septum resection. That is complicated. You go into Asherman syndrome, especially if it's very grade 3, grade 4 Asherman's. Please do not attempt this unless you're very fully aware. Endometrial ablations, these are a bit complex unless you know what to do and you know all the principles well. So know your limits and stick to what you can do as you grade up your skill level. Patient safety always first. Bipolar energy and shavers are safer than using monopolar energy because of the fluid challenges with monopolar. Follow adhesion prevention strategies, so work in the right planes, keep in check on how to do it, and use some obstructive, something to obstruct the adhesions forming again. There are different options. That's a different talk later. And some procedures may need a second sitting for completion. So if it's a very big myoma, you may be able to do part of it and then your fluid deficit reaches the max and then you'll have to stop and complete it at this. Please do not continue beyond the fluid deficit margins that we have set. And sometimes even in Asherman's you may have to do it in more than one sitting to get a partial cavity open and the next time a bit open and then the next one a little larger open. I've had to do some Asherman's in 3 sittings for patients who may not have had periods for 8 years or 7 years, and it was a completely obliterated cavity. But after the 2 or 3 sittings, they have a cavity, they have an endometrium that's regrown, and they even have periods. One of them even got pregnant, unfortunately did lose the pregnancy in 2nd trimester, I think because of poor blood supply to the baby, and we had an IUFD. Finally, the uterine cavity pressure should be the lowest necessary to distend the cavity. So don't use very high pressures. Ideally keep around or below MAP. Use of normal saline with bipolar energy reduces the risk of hypernatremia, but overload is still an issue if you don't keep your limits properly. And most complications in hysteroscopy are entry related, so make sure entering of the hysteroscope under visualization vaginoscopically is actually the best approach. Thank you. Bye-bye.